Well, I'm going to get this introduction started. We may as well get started. And if people want to join, I think that will be okay. Um, you're wrapping up the day for us. We have Dr. James Wheless from the Bonheur Children's Hospital, Memphis Children's Hospital. We're going to be talking about what do we do when seizures happen at home or at school, which is actually a great topic. Okay, Dr. Wheless, take it away.
Great. Thanks for inviting me to be part of this. Let me just, before we get started, kind of remind you of what you may not appreciate, which is that we're in a bit of a paradigm shift as far as how we approach patients with epilepsy. And I'll link in this to what happened in the world of asthma probably 20 or 30 years ago. So before that, folks took regular medicine daily if they had really bad asthma. Our medicines were more limited. But if they had worse trouble breathing, they were stuck going to the emergency department, or they could try and tough it out at home and hope it would pass. And nowadays, folks with asthma had a lot of different inhaler options, so they can take medicine regularly if they need it, but they can use their inhaler when they need it, when they get worse. And for most of them, the vast majority, that allows them to not have to panic about how far away is the hospital, where is a hospital, I got to get to a hospital. And really to carry on with their life. So that kind of shift in how our colleagues approach patients with asthma, I think is what we're just at the front end of experiencing in the world of epilepsy. So what do I mean by that? So in epilepsy, we've always had daily medications for folks to take, hopefully to keep their seizures controlled. But if they had occasionally days where they had several seizures or they had just a cluster of seizures, they really had not much choice in the past but to go to the hospital, or like our patients with asthma, kind of tough it out at home. There were some options, but they weren't great and not embraced by most of our patients. So what's happened in the last couple of years, we've really had an explosion in therapies that are easy for patients to use at home. They're acceptable to patients. They're easy to do, and that allow patients and their families to safely treat these clusters at home. And doing that, the vast majority, just like our asthma patients, don't need to go to the hospital. Some still may, but the vast majority do not. And that's really improved the quality of life for our patient, for their families, for everybody around them, because they can kind of get on with their life also. They can, go on vacations, they can go on trips, they can be at school and not think, where's the closest emergency department if I have a seizure emergency? So that's what we're going to talk about today is, what are these new treatments? What do we know? What's changed our thinking about how do we approach seizure emergencies, and especially the ones that can be dealt with now at home or school or work, wherever, but you don't have to go to the emergency department for every one of these. So before we get into the actual treatments, I thought I'd kind of review kind of where we are with these seizure emergencies and the terminology we use, so we're all on the same page. So we know that folks can have, intermittent single seizures. Some folks may have no seizures, but there are different types of seizures for each patient that can represent an emergency. And that's usually when they start to have multiple seizures the same day. The multiple ones may be longer, stronger, the recovery may be slower than their typical seizure. So it's clear to the patient, to the families, that this is different from their regular seizure. Now, in the US, the Food and Drug Administration, the FDA, has official terminology for these, and you see that listed at the bottom of the slide. They call these seizure clusters, or acute repetitive seizures, or ARS. So that's the kind of official language that the companies have to use to get their products approved. But to be candid, that language is not something that translates well between doctors and patients for us to be understanding each other and what we're talking about. So we talk to patients, what we really see is that the language that resonates better for me as a physician and for families to understand what I'm trying to get at is when we ask, do your seizures ever cluster or repeat? And repeat's probably the great word, close together in a unique pattern that's different from your usual seizure. So if a patient's usual seizure is 45 seconds to a minute and a half long, They recover after 10 or 15 minutes. They may have one that day. Rare days, they may have one in the morning and one at night, but even that's rare. Then we say, okay, that's your usual pattern. But now if you get up in the morning at 9 o'clock, you have a seizure. Then at 9:45, you have another one. Then at 10:30, you have another one. We say, wow, these are recurring and they're repeating close together. This is not typical. This is a cluster or an episode of frequent seizure activity that we need to treat before it progresses to a worse seizure emergency, and you do end up needing to be at the hospital. So that's what we're talking about, is those type of seizures. As you can see, I've not put a time limit on that. The FDA does not say it has to last this long before you treat. The only thing they kind of say, and what we as doctors say, is it should be different from your usual seizure. And usually we ask families are great at telling us that, it's different. And I started to get anxious. I mean, I'm kind of know what to do with their usual seizure, but this was different. The pattern was different, how they were happening close together. And I was starting to get a little worried. And that alone is usually that gut feeling that families have is a really good sign as well. So what do we understand about when patients have these kind of unique seizure where they repeat in clusters? What do we understand about those? Well, if we look at the United States today, we estimate there's between 3 and 3.5 million people in the country that have seizures. If you go across the age spectrum, all seizure types. But how many of those people, will have these seizures that repeat? We don't have great data, unfortunately. The best estimates we have, and I think this is probably low, are that it's maybe about 5% of folks, 1 in 20. But as you can see, that's still 170,000 patients. I think it's low. I think it's probably closer to 10%, which would double this figure to 350,000. And then if you look at people that say, well, gosh, I haven't done it in a year and a half or 2 years, but I did once in the past. And now I'm driving to go to Florida, to Disneyland, or I'm driving to the beach for a vacation. And along the way there's not hospitals. I'd like to have something for just in case. Then you expand the number even more. Excuse me. So we know there's a huge number of patients, but beyond that, the big kicker is that we talk to patients and say, gosh, if you were to have a cluster where these seizures repeat, if you were to think, this is different than my typical seizure, I'm concerned, I can end up in an emergency department. How many of you actually have a treatment prescribed by your doctor and know what to do, how to give it, what to expect? It's only at best 1 in 5 patients. So the vast majority do not have a treatment. These are the folks that are kind of told, we'll stay calm, let's see what happens. So you're kind of waiting it out, hoping for the best. Now, in general, obviously, with any kind of medical emergency, staying calm is great advice, but it may not prevent the next seizure, unfortunately. All right, what happens and what is the problem for our patients that have seizure clusters? Excuse me, I'm going to get a drink. Well, we know the clusters, much like their seizures, are not predictable. If we could schedule them, it would be great, right? We could say, oh, it's going to be at 7 on Saturday. I won't plan anything that morning. We're good. We can treat it. We'll work around it. So the fact that it can occur at any time is very anxiety provoking. And then when we look at patients who have kind of these seizures repeat and ask them to keep track of them and look at their diaries, we see there's a lot of variation between patients. So what you see on the right side of this slide is some patients' seizures will repeat in less than an hour. So that's the kind of light green bar. Some will be 1 to 2 hours, some over 2 to 3, 3 to 4, even up to 4 to 6 hours, yellow bar. But a lot of patients will have their seizures intermittently over 6 to 12 or even up to 24 hours, a full day, when they have a quote unquote bad day. So if we're going to treat them, since some people can have a lot of them up front, we want something that works fast, but a lot of people will have them intermittently all day. So we need it to not only work fast, but we need it to last. So we need kind of both of those goalposts. We want it to be fast and we need it to last as well. So what are the challenges for our families that have a loved one with seizure clusters? Well, we talked about this a little bit, whether we look at adults with seizure clusters or children and their caregivers, is not knowing when they are going to occur is incredibly anxiety provoking. So not only is the seizure put the patient at risk, but the ones around them report a significant amount of emotional burden, just not knowing when this is going to happen and not knowing what to do and how to respond to it. But beyond the kind of emotional and kind of quality of life consequences for everybody involved, the patient, their family members, there can be significant medical consequences, right? We know that when our patients have these bad days where their seizures uptick, that some will go to the emergency department, so it can lead to emergency department visits and ultimately hospitalizations to kind of calm down the seizures because they don't have an at-home treatment. And while I would always say that if your seizures are really, if you're having trouble, yes, the emergency department is a place where you can go to get therapy. We know in the modern era, that's not ideal, right? With COVID, we really did not want people going there for other reasons, just because of the risk of exposure to COVID. And now even that many places in the country are doing better with COVID, many of our emergency departments and hospitals are way understaffed. So there can be huge wait times if you go there. So even going there, you may not be treated promptly. We know on the bad days where you're having lots of seizures that if people are up moving around, they have a seizure, they're at risk for fall and injury. And then the ultimate worst injury is we know that a certain number of patients where their seizures repeat, if that's not interrupted, that they will progress to where they have status epilepticus, and that some patients, unfortunately, with that will die during that. So the worst injury, obviously, is death. So there's a lot of reasons to say we really want to jump on this with treatment and ideally treat it and stop it before it ever gets to the hospital. But we talked about that many of our patients do not have a treatment plan. So what are they doing? So we talked about this 80% at least. So the vast majority of patients do not have a medication they can use. So we see that whether it's the patient or their parents or caregivers, if they really get panicky, if it's a bad day, they're having a lot of seizures, they use the emergency department, right? We've already talked about the downsides of that. But the other downside we didn't kind of talk about is when we treat these seizure clusters, what do we know about, how well our treatment works? Well, the one thing we know is that the earlier in the seizure cluster we give the treatment, the better it works. So in other words, if we have a day where we say, gosh, we have a first seizure at 9 a.m., second one at 9:30, third one at 10:15, if we treat after that 10:15 seizure, our treatment's much more likely to work than if we wait and treat after the fifth or sixth or seventh seizure that day, even if we give the same treatment. So we want to treat early on. And the problem is if we go to the emergency department, well, one, nowadays, because of the fallout of COVID, we have huge delays in the emergency department. But even in the best case scenario, and this is data from prior to COVID, what happens when you get to the emergency department? If I've had a loved one who's had a couple seizures at home, I show up there and say they've had a couple seizures. If they're not having a seizure at the time I get there, they'll be put in a room, right? So I have all that time I didn't treat them while I was driving there. I kind of get processed and triage in the emergency department. I get put in a room. I have to wait to be seen. And then say I have another seizure after I've been there 15 or 20 minutes, then they'll treat me. So there's huge delays, both the time to get to the hospital and after I get there, the time to get treatment. And we've already said that the earlier we treat, the better. So having rescue therapy, having medication that can be safely given at home is a huge advantage in many aspects. And what were our options in the past up until the recent treatments? So we had Diastat rectal gel, which was a diazepam, the chemical in it. It was available, and it was available since 1997 when it was approved. So we've had it for over 20 years. But even though we've had it for that long, if we look at the use, just as you might guess, the vast majority of use is in preschool and young children, because as we get older, the objections to just giving a medication rectally in someone's bottom are there. And a lot of people say, you know what, I'm just going to not be treated and take my odds that, this gets better. For patients that had their seizures well spread out in the cluster, so they were an hour, maybe 2 hours apart when they repeated, and between the patient was awake and able to swallow, we could give them medicine to swallow they just took at the time of their cluster. So often oral diazepam, sometimes oral lorazepam, or we could get what are called wafers, so tablets that are meant to melt in the mouth, and clonazepam wafers, the most common one there. The problem is many of our patients have their cluster start at night. So if they start at, in their sleep at 10 at night, they have it, they're kind of confused, they fall back asleep, they have another one at 10:30. They may not be awake enough to safely swallow medicines, and so it's not a great option. And then if we need to give medications in the vein or in the muscle, that's usually something we only do in the hospital. So up until very recently, we only had a single option, and that option, unfortunately, was not utilized by most patients with seizure clusters. So how can we tell when I'm seeing patients in the office, who really needs a rescue therapy? And you could argue everybody with epilepsy should have rescue, just like, I have a spare tire in my car. Now, knock wood, I haven't had a flat and had to use a spare in over 20 years, but you know what? I still carry a spare. And, some people would argue that, gosh, they take care of adults that have not had a seizure emergency in 10 or 15 years. Do they really need it? Some would argue it's like that spare tire. It's probably not a bad idea to have on hand, but there are some folks that we know really need it because they're definitely going to have at high risk for seizure clusters. So who are those folks, and can we identify them? So we know folks that have more severe epilepsies that is not totally controlled to begin with. So they're not seizure free. They haven't gone a year, 2, 3 years seizure free. They're at higher risk. If they have what we call remote symptomatic epilepsy, which means there's an underlying cause. So maybe they had a near drowning, birth injury, they had a head trauma, stroke, they're more higher risk. There's certain areas of the brain that the seizures come from, and based on EEG that we know put them at higher risk. Patients that have had seizure emergencies with nonstop convulsions that have required emergency room visits and required medication to be given at the emergency room, they're at higher risk. The longer your duration of epilepsy, and the folks that start in early in life. So there are some things that tell us like, wow, we should think about it for this patient because they're at higher risk. But, like the spare tire analogy, you could argue this could be a lot more folks. So what do we do as physicians? So, we look at patients, we say, well, we've got to get a history, see if they have any of those things. We'll ask the obvious question, which is, typically you have a single seizure. Do you ever had days where they repeat? Because if you do, we need a treatment for home. Are there triggers? Because if there are triggers for when they repeat, then we should try and avoid those, the obvious things, right? We just listed some common ones here. So those are things we can do. We're seeing the patient. And then the next step, obviously, is what do we use for their rescue? And there's several different agents. I won't tell you there's a single one that's kind of best, because we kind of individualize which treatment goes with which patient and which family. So let's kind of walk through what's there. So we've talked about once you're in the hospital, you can get an injection. That's usually reserved for hospital or ambulances. At home, we have the rectal Diastat you see pictured on the bottom left. We have intranasal products that you see here in the middle and on the right. And I'll talk about one of our buccal products. And buccal just means it's placed on the inside of the mouth, usually against the inside of the gum there as well. So let's kind of look at these, but I want to step back first and kind of, because some of you may be thinking, gosh, she's talking about seizure emergencies. What about people that have bad allergies? What do they do for emergencies? And everybody knows about EpiPen, right? If you have, bee sting and you're prone to stop breathing, or shellfish allergy or something, you carry an EpiPen with you. It's got a button on the end. You take off this gray cap, you just hold it against your leg. You hit this button and it automatically injects you. You don't see the needle, you're done. If you have pants on, like in this example, it's a small needle that will penetrate and it saves your life, right? You can breathe again, you're good. And so people said, gosh, why don't we have that for epilepsy? That's what people with allergies carry around with them. Well, that was developed for epilepsy using diazepam. The studies were done, as you can see here, and published almost 8 years ago now, 7 to 8 years ago. Uses a very similar device with an injection in the muscle. And if we look more closely, it's the same kind of thing. It's an auto injector. It has a little button you push at the bottom. It automatically injects. You don't see the needle because this is against the skin, the kind of end. And people are probably thinking, gosh, then why don't we have that? Well, the military has that. The US military has carried this on their personnel when they're in a combat situation for the last 7 years. They carry this along with a couple of other injectables in case they have a nerve gas exposure to prevent seizures from that. It's not been developed for civilian use as of today. It might someday, but the thinking was that a lot of civilians may not want this. For EpiPen, if you're gonna, risk, I can't breathe, then you might not mind giving yourself a shot, if you will. But for seizures, people said there might be other ways we can go. But I mentioned that just because that does come up sometimes, is why don't we do the same thing for epilepsy? So what are the options that are really out there? So I separated these based on kind of the chemical, if you will, that's in them, because there's two main chemicals that are, kind of occupy this space currently. There may be some new additions down the road, but they're all from the same family, if you will. They're all from the family of medicines that we call benzodiazepines. So it's the benzodiazepine family. The two main ones are diazepam and midazolam. So I'll talk about diazepam products first, and then we'll look at the midazolam. So I just want to show you the four, and we'll talk about these each in a little more detail. So I showed you the one that's the shot, the diazepam injection, which is Vanquix on the upper right here. The military has that. We do not have that. I don't think we will right away. We'll talk about the ones we have, the rectal gel, the first one approved in 97. The nose spray formulation, Valtoco, approved in 2020. And then this film preparation, much like a Listerine film that you're used to, that would you put inside the cheek and the gum, outside the teeth, gets in immediately. Hopefully will be approved by year's end. So we'll see. That's maybe a 2021, could be early 2022. So let me walk you through the diazepam products just to show you how those are used and talk about those. So diazepam rectal gel, I'm not going to spend a lot of time on because it's, like I said, it was approved in 1997. So it's been out for 20 plus years now. It's a rectal administration. So you can see, I didn't go through all the steps. You can see there's over 12 steps. So it's a bit more complicated to use, but at the end of the day, you're given the medicine the bottom. You have to hold the buttocks together after you get it so the medicine doesn't leak back out. As you can imagine, this can be complicated. Imagine your loved one is 180 or 200 pounds. They're a big person. You've got to lay them flat, get to where you can give the medicine, separate their buttocks, give the medicine, hold them together. Obviously, that can be complicated. It can be tough depending on what social situation you're in, size of the patient, other problems. It works, so it's out there. It's great, but it can be challenging, right? So let's look at kind of maybe other formulations that were developed. So that medicine was approved in 97, but immediately after it was approved by 1999, many of us were at a meeting and recognized, you know what, we really need other ways to give the medicine. And if we could put it in a nose spray, it would be great because it would get sprayed up the nose here and directly uptaken into the blood vessels that go to the brain. So we really get the product there. It would be a much more acceptable way to give it as well. But there were challenges to doing this. The FDA that controls kind of approval of medicines has very strict guidelines of kind of when you give it, this kind of spray flume that you see here, that has to be uniform. There has to be no priming. So when as soon as you hit the trigger, it has to be ready to go, right? You can't be priming and not knowing how much drug you've wasted. It has to be a tiny volume. This whole mist, when you condense it to liquid, is 100 microliters, which is the equivalent of 2 drops. So we have to put all that medicine in a teeny little bit, which means we've got to figure out how to get it to stay there, as well. So there was a lot that goes into making an intranasal product, although putting it in the nose obviously is much more attractive. So the Food and Drug Administration has a nice guidance about all the things they require. And we finally have two intranasal products, Diazepam and Midazolam. I'll mention both, but we're on Diazepam now, so we'll start with that one. The medicine, I just want to remind you, is given into the nose. There's a really small area here that's targeted just inside the nose where the medicine can be absorbed. It's a teeny area, so we have to get the medicine to a small amount of liquid. Like I said, about 2 drops in one side of the nose. We can put that much in the other side, but 2 drops. So Valtoco I'll talk about first because it's the Diazepam product approved in 2020. You see the formal approval here. So it's intermittent frequent seizure activity. So we talked about seizure clusters or seizures that repeat close together that are distinct or different from the patient's usual seizure. So if I normally have 2 a day, then to have a day with 2 is not different. But a day with 3 or 4 is. If I have 1 a day, or even if it's 1 every 8 months, but I never have more than 1 a day, then 2 a day could be different too. This is approved for age 6 years and older just because the studies that were performed went down as young as 6. Studies are just starting from age 2 to 6. So down the road, this may go lower, but as we sit here today, this is just down to age 6. The Diastat rectal gel I talked about goes all the way down to age 2. So for our younger patients, that's still the only option that's available. So we talked about this. This is a nose spray. So the idea is that it has a tip that's put in the nose. We'll talk about this more. There's this button you push on the bottom. The medicine is immediately given in a mist into the nasal cavity. It's absorbed by the blood vessels you see here, the same blood vessels that go to the brain. So you get really quick uptake and quick penetration to the brain to stop the seizures. So what makes this work? So we have diazepam, which we know is a very effective anti-seizure medication. It's really effective for stopping seizures and for seizure emergencies. We don't tend to use it for regular medicine, but for seizure emergencies, it works great. It was introduced in the United States in 1963. So we've known about diazepam for a long time. And by 1965, it had its first use in treating seizure emergencies. So again, an old friend, we've known about it for ages. We know it works very nice. The problem was, how do we get this into that teeny little bit of liquid I talked about, the 2 drops? So we figured out that this is it likes to be dissolved in basically oil or fat. So we can dissolve it in a teeny amount of vitamin E. And vitamin E, we all know it's in skin creams, lotions, teeny amounts we can put on our nose, not going to be irritating, not going to be a problem. We're not inhaling into our lungs like people that vape in big amounts, so we're not creating lung problems. It's teeny amounts, but it allows us to dissolve this. So we could get it into the nose that way, but then it would just sit there on the lining of the nose. And we want to remember to penetrate the nose across kind of that lining into the blood vessels. So the reason this product took so long to develop is we had to wait until we had Intravail. Intravail is the kind of the brand name for the special sauce that kind of makes this all works. What the Intravail does when you mix it with the diazepam and vitamin E is allows the diazepam to go from the surface of the nose, kind of it relaxes kind of the spaces between the skin and the nose, just temporarily, and lets the diazepam get across into the blood vessels and get up to the brain. So it's the special sauce that really makes this all work. It's not toxic. It's broken down much like a sugar to carbon dioxide and water. And we know from the studies, and I'll show you the data, very safe, easy to use. So this kind of components allowed us then to have a nasal spray that would meet FDA criteria. The FDA reviewed all the data and said, wow, this works. And not only does it work, but the FDA labeled it clinically superior to Diastat. And you can only be clinically superior in a couple of ways, but you can see at the bottom, they said it was a major contribution to patient care over the rectal route. So maybe not a surprise, would you rather have the medicine sprayed in your nose or put in your bottom? Not a surprise that the FDA said, wow, this is better than going in your bottom. It's less invasive, easier to use, especially in a seizure. So this is the one time you might say, wow, I agree with something the government agency actually said. So let's look at how it works. So we did lots and lots of patients in the studies, and you can see lots of seizure episodes. So all total, well over 4,000 episodes where patients had seizures repeating. were treated over the course of the year plus of this study. We asked patients, every patient was different, obviously, at what point they would treat. But once you treated the emergency with this product, Valtoco, write down if you have any seizures in the next 24 hours or not. And even if you go like, say, 3 or 4 hours, you get a break, but then they start to come back and you're worried and you give a second dose, we want to know how many people did that. So you can see if we just look at the people that used a single dose, because remember, we wanted it to work fast, we wanted it to last, that even when we get out to that last part, 24 hours, not quite 90%, but 86%, they only needed a single dose and they were done. It interrupted that seizure repeating. No need to go to the hospital, no need to move on, we're good. So really seemed to work quite well to do what we need to do. It's easy to use, no one was confused, people were able to understand how to do it. If we look at side effects, they were really pretty minimal. A couple of people said, my nose is a little uncomfortable, it was mild. Some people said, you know what, I feel a little congested from just the volume, the mist. A couple people had epistaxis, or afterwards when they blew their nose, a little bit of blood on the tissue, but not frank nose bleeding. No one had any breathing problems. No one had any serious problems that required them to go to the hospital related to treatment. The other important thing is people were allowed in this study that had bad seasonal allergies. So even folks you say, well, gosh, a lot of times they have allergies, maybe their nose has got stuff in it. This still worked because of our special sauce, the Intravale. It would still penetrate, it would still work. So it worked across the board, across the age groups from age 6 all the way up well into adulthood. The device was the diazepam, and the amount given was dosed based on weight, depending on if you were less than age 12 or greater than age 12. So very similar to what we do with Diastat. How does this product come? So you can see it comes depending on the dose you end up getting. So 5 and 10 milligram doses are used in our pediatric patients, not in adults. In each box is 2 doses. And each dose is a single applicator for these doses. You see it here. And on the cartoon to the right, you see the applicator by the nose. You just give a spray. The applicator looks just like this, and we'll come back to how it's actually dosed in a second. For adults and adolescents, they may require a bigger dose, 15 or 20 milligrams. If you're my size, you're 20 milligram adolescent or adult. If you're a petite adult, if you're down around 100 to 115, 120 pounds, then 15 milligrams is your dose. For the 15 milligram dose, again, each box, there are 2 doses, but the single dose requires 2 applications. So in other words, each of these has half the dose in it. Same with the 20. Each box has 2 doses, but each dose is 2 applicators with half the dose in it. So you can see in the cartoon on the right here for the 15 and the 20, you use both applicators, 1 in each side of the nose. So that's the big difference in adolescents and adults. You get kind of half the dose in one side of the nose, the other half in the other. Whereas in our pre-adolescents, it's just all able to be contained in a single spray. How is it administered? So you saw the device. This is a pretty standard device. It's used for other products that are given in the nose. It's the nozzle that goes in the nose here, and then the plunger that you hit. You just bring it over to the nose. You can rest your fingers like this against the nose, put the tip just in the nose, and then you hit this. And when you do, you hear that click. As soon as that's done, the medicine's in. The patient is lying down in this picture as though they had a seizure on the sofa or in the bed. If they're sitting up in a chair like I am, you do not have to move them. That's the beauty of these products. You just put it in their nose and give it to them. The patient does not have to cooperate. They don't have to breathe in with it. They can be, not recovered from their seizure. They can even still be in the seizure. It will work. So that's the real plus for these medications. If their seizure cluster or repeating seizures are interrupted with this, the patient's recovering, and then hours later, they start to go back into their seizures and family members are worried, you can repeat the dose. We know that's safe to do, to give 2 doses in a day. Not a problem, even the full dose, okay? Better than the seizures. All right, what about the other formulation? I talked about this oral buccal soluble film. Okay, don't get too far ahead of me yet, because this one is not available yet. It's sitting at the FDA. It's on someone in Washington's desk. We're kind of waiting for them to approve it. We're hoping that happens by the end of the year. Could be next year. It's this one here. It's diazepam. It will be brand name Libervant. There is a similar product in the same family. For those of you who noticed the last kind of name here, that's in that benzodiazepine family. That's clobazam, that's used for routine treatment of seizures, called Simpazan. It's made by the same company. But I just wanted to show you this to show you how it comes. These are film strips. They look like this. So much like the kind of Listerine strips, they're different sizes, and the diazepam will come in different sizes too, depending on the strength. So different strengths depending on child or adult. How does this work? So the film has embedded in the film is our diazepam. So our drug's kind of embedded in the film. So much like the Listerine film, you take the film out of the package, which is a thin package, just like Listerine. So it's nice. It's a little teeny package. You put it against the side of the cheek and the mouth here, so you don't go past the gums with someone having a seizure, obviously. It's applied there. And then in the seizure case, the diazepam, it's stuck to the side of the gums, as you can see here in our cartoon. It gets into the blood vessels directly there from the cheek and goes to the brain. So it's really a nice strategy to use, again, to avoid the rectal administration of drug. So those are our diazepam products. But I also mentioned midazolam is another member of the benzodiazepine family. These are the two that currently are used. So there's a midazolam product. This is the shot formulation that's used by our emergency medical technicians in ambulances sometimes. If you end up in an emergency department, sometimes they'll do this. They'll just give you a quick shot there. It's called Seizure, but it's that midazolam product for shot. We're obviously not using this at home. In Europe, so the UK, they have a couple of products that are what are called buccal midazolam. So you can see it's given in the gums. It's the same midazolam, different strengths and different sizes, again, depending on how old and how big the person is they're treating. They have a little bit different approval there. Their products are approved for what they call prolonged acute convulsive seizure. So someone that's having a continuous convulsion, not what we see more frequently, which is someone having kind of frequent seizures back to back that we'd like to stop before it becomes continual as well. There is a different approval process in Europe, and I just want to remind you of that. It's different from the United States. So in order to get that buccal formulation of midazolam approved, they were able to compare that midazolam, which is MDZ, to diazepam kind of liquid given in the bottom, and say, comparing the two, basically the midazolam, what worked and it was like. This is a very different study than the FDA would allow, because people knew what medicine they were getting. It was not controlled from that standpoint or randomized. So while in the Europe this is acceptable, in the US this would not kind of be good enough for the FDA to approve the medication. So the midazolam product that we have is a nose spray, as you see here on the right. So the idea for this, this nose spray was approved by the FDA in 2019, but again, this goes way back. Our anesthesiology colleagues were using a midazolam for patients to having minor procedures to sedate them back in 1990. And by 1994, several neurologists were kind of making homemade nasal products to use for seizures. And what do I mean by homemade? So what they were doing, as you can see on the left here, they were taking the product that was meant to be given in the hospital, this shot formulation. They were putting it in a syringe. They were attaching to the end of this what's called an atomizer. So when you push liquid through it, it breaks it up into a fine mist spray, and then giving this to patients to spray up their nose. So this was a problem because it was more complicated. While it breaks up the liquid, it's still a much higher volume than you can absorb, because this was a total of 1 ml for a dose. For some patients, that even was half a dose. And remember, we said that we need to get this down to 2 drops. Well, 1 ml, just to give you an idea, is 20 drops, and many patients require 2 mLs, which is 40 drops. There we're getting a huge volume compared to what we have in here, which means a lot of it was being swallowed and getting in. So the idea behind Midazolam was to say, okay, we know that this kind of works, but let's do this in a better way. And that was the concept behind Nasolam, which is our current product available. So you can see that this is approved. It's ages 12 and above. So again, just because it wasn't studied below age 12 doesn't mean it's not safe, but it means that for us to prescribe it is very hard below that age, because that's kind of the insurance approval based on the studies that were submitted to the FDA. So remember, age-wise, we have Diazepam Rectal Gel that's age 2 and above, Valtoco, which is Diazepam Nasal Spray, age 6 and above. If we get Libervant, the Diazepam oral buccal soluble film, that will be initially age 12 and above. And then Nasolam, the intranasal Midazolam, is age 12 and above also. So we have a little bit different ages for these. This box contains 2 doses. Each dose is 5 milligrams. And you can see it's the same exact nasal spray as our other product. All of these use the same exact device, if you will, because it's kind of time tested, incredibly simple, and works. The Nasolam studies were a little bit different. I just point this out as far as repeating doses, in that patients got a 5 milligram dose. So 1 initially. If their seizure stopped, great. If they didn't stop within 10 minutes, they could get a second dose in the other side of their nose. So the first dose in one side, the seizure didn't stop within 10 minutes, second dose on the other side. So that's how the studies were done. Many patients got by with just a single dose. You can see here, so kind of a single dose, but some needed 2 doses, which is this black line here. So how do we use that in practice? In practice, we start off with almost everybody getting a single dose and saying, if you have seizures that repeat, try the single dose first. If it works, great, then you can get by with a single dose. If the first time you do it, you give 1 dose, it kind of starts to work, but then the seizures come back and you end up giving a second dose, whether it's 10 minutes or an hour. Then the next time you have a cluster, just give both doses up front. Give 1 on one side of the nose, other on the other side of the nose. You do not have to wait kind of that 10 minutes. You've kind of proven that you need the bigger dose to stop your seizures. So that's kind of how we've handled it at our center. What about side effects for the Nasolam? So again, no respiratory problems were seen during the trials. Similar side effects that we saw with Valtoco. So nasal discomfort, maybe a little runny nose, being tired. Having said that, we asked our patients to record, after you have a seizure cluster, we know that takes a lot out of you. Oops, sorry. Then you get the medicine. It could make you a little tired. How long is it before you get back to normal? Almost all said they were back within an hour and a half. So pretty quick to get back as well. All of our benzodiazepines, so Valtoco, Diastat, Libervant, this Nasolam, they all should carry this class warning to not use them in a patient that's taking opioids or narcotics regularly, because they can affect their breathing or stop their breathing if used in combination, which obviously is not good. So we like this return to baseline quickly. We saw that with our other products as well too. So we dose this, I've talked a little bit, but it comes in a box that has 2 doses in it. Initial dose is 1 spray. You can give a second spray as well. And much like the Valtoco, they both carry the recommendations that in general, you shouldn't be using it more than 5 times a month. Try and avoid regular use. The reason is if you use it basically frequently, it will probably not work as well. So we want to use it for kind of, keep it for emergencies when we need it, we'd like to have it. All right, so let me just finish up on seizure action plans, and then we'll have time for questions. So now that we have all these great treatments, and we've talked about most patients do not have them available, we need to develop seizure action plans. So what do we mean by this? This is me talking to the patient, figuring out their regular seizure, they recover, they don't need anything other than just someone to be there, someone to do basic first aid for seizures. But then they have their seizures that repeat. At what point are we going to kind of pull the trigger, if you will, and say, you need to use one of these rescue agents because this could be a seizure emergency. And in my practice, I tell my patients, I'd rather err on the side of treatment than not treatment, because if you think you're progressing to emergency, you're at home, you're by yourself, you have to make that decision kind of in real time. It's a lot easier for me when you see me in clinic to be a Monday morning quarterback and say, gosh, I don't know, I might have waited, but I don't think that's fair. You're there in real time under the pressure of kind of that loved one, that emergency. What's the worst thing that can happen? Well, if maybe the seizure was going to stop on its own, the repeating was going to stop, but you treated it anyhow because you were anxious, you weren't sure, you wanted to stop before it got bad. We said that, you know, some of our patients may take a nap, but most return back to where they were before within an hour, hour and a half. So the worst thing is they may take a nap, not going to harm them any other way. The best thing is that you may prevent the seizures from progressing to a real medical emergency where you're in for the emergency department. And if you're at grandmother's, if you're at the lake, if you're on vacation, then an hour and a half, you can get on with your life instead of trying to be waiting at a local emergency department for hours and hours to be seen. So we know that most of our patients, we survey patients on the pediatric side on the left, on the adult side, it's even more dismal, I'm sorry to say. Less than half of pediatric patients, families, caregivers, parents have an action plan. They don't have a plan of when do I do this? When do I, you know, kind of have to jump in and help out? And on the adult side, you know, less than 1 out of 3. So we really have a lot of work to do here, kind of talking to our families, saying, what do we do? So what works and what do we do? So we need to kind of figure out each of our patients, you know, when is it different? Remember, we said this is different from their usual seizures. We need to figure out which rescue medicine fits with our patients so we can prevent all these problems on the right we talked about. Do they want to use the rectal administration? Because this is a 20-month-old, and that's the simplest and easiest thing. If we're using a nose spray, which one do we use? Which insurance plan maybe has no payment, no copayment, or no low copayment for one over the other? We use a film, which patients are better for that, and what is the family comfortable with? At the end of the day, no matter which way we start, when we see patients back, we need to be reviewing that seizure plan and saying, when you did it, if you did use it, did it work? If it did, great, stick with it. If not, why not? Was it because you waited for the 4th seizure and we talked about giving after the 2nd seizure and you waited late and that's why it took longer to work? Because the longer you wait, the medicine doesn't work as well or takes longer. So let's move it up to 2nd seizure. Or no, you gave it after the 2nd seizure, but you just had a hard time and you want to try a different product. Or some products may work better for one patient than the other. So the key is having the plan, but then like every emergency plan is after you implement it, you should review it and see if there's things we can do to improve it, okay? So I hope that gives you a feel, because this is a real paradigm shift in the world of neurology and epilepsy. Because in my mind now, our patients with epilepsy have regular medicines or treatments they take every day. But then now we have the capability to give them something they can do when seizures kind of uptick, when they repeat, when they're getting worried, when they're having a bad day. And we have enough options that every patient should have an option available. So I hope that that gives you a feel of where we are. More options will be coming down the road, so stay tuned. There'll be more if you think that you would like other options on top of these. So let me stop there. I'm happy to answer questions, and I appreciate your attention for those of you that's evening or we're getting into afternoon, even on the West Coast. Thanks.
Thank you, Dr. Wheless. If anybody has questions, you guys can put them up on that chat, and I'll read them to the doctor. Otherwise, you could actually unmute your microphone if you have a question that you'd like to ask yourself.
And we've gone from sunset in Memphis to, now dusk. Well, I'll change my background so it's appropriate. You can see what the bridge over the Mississippi looks like with the downtown in the background in the evening hours.
I like the scenery change.
All right, and I'm looking at the chat is, so one of the questions has come in, and that's a great way to put them in if you want to do that as well. Should every patient with epilepsy have a seizure rescue plan, even if well controlled for years? So I think, yeah, that's a great question, because you can argue, gosh, every car comes with a spare tire, but there are folks that say they've never changed it. So do they need a spare? I think you can almost make the same analogy here. Obviously, if you've gone, gosh, 10, 15, 20 years, you've never had an emergency, then okay, you've probably proven that your epilepsy, while you may have seizures, if you totally came off treatment, you never have where they get so bad that it's an emergency, that your brain knows how to prevent that, if you will. So I think there are some folks you could argue, okay, maybe they could get by, but the vast majority of folks with epilepsy, I think, should have it available as a backup. And the nice thing with a lot of our treatments is they have what we call a long shelf life, which means they're good for 1, 2, 3 years. So they don't expire quickly. So even if you don't use it that frequently, you can kind of keep it in a travel bag if you're using it when you travel, to have something available. If it's mom's purse, if it's at work, wherever. It really allows that luxury without being worried that, gosh, I keep buying all this medicine, I'm not using it, and then I'm throwing it away. Good question. All right, other questions out there?
Not seeing anything else pop up yet. I hate to keep you all night, Doc. I know it's 2 hours later by you. If anybody does have any questions on the rescue meds or seizure action plan, go ahead and email us at the event at, info@epilepsyawarenessday.org. We can definitely forward that over to Dr. Wheless, and we'll get you an answer.
All right, let me thank everybody for their attention, kind of late afternoon, early evening, and late evening, depending on where you are, and appreciate the opportunity to update everybody.
And thank you too, sir. And I'm going to be chasing you down for Disneyland next year.
All right, look forward to it.
Thank
Bye-bye.
you. Have a great day.